My name is John Hummel. I'm the Director of Electrophysiology Research at The Ohio State University, and I was one of 3 national PIs on the JEWEL-IDE study. I think that when it comes to wearable defibrillators, when you look at outcomes from previous trials using these systems, there are variable results. For instance, the VEST trial looked at people post-myocardial infarction with reduced ejection fractions and randomized them to a control group with just goal-directed medical therapy versus those that were on goal-directed medical therapy that had a wearable defibrillator. And the intention to treat analysis showed no benefit in terms of risk of sudden cardiac arrest or arrhythmic death with the treatment group compared to the control group. If you look at the VEST trial, patients on treatment that actually wore the defibrillator had a survival benefit. And this was really the impetus for the development of the patch-wearable system, to develop a wearable system that actually patients tolerated well, that they would actually wear, in hopes that if you had something that patients had high compliance with, that we would actually see a survival benefit in these patients. The trial was designed to test the use of the device in patients at risk for sudden cardiac arrest. These were patients with ejection fractions of less than 40%, with either an ischemic cardiomyopathy, non-ischemic cardiomyopathy, myocarditis, or recent myocardial infarction, or patients that did qualify for an implantable defibrillator but didn't meet the indications for permanent implantation yet, or it had their device removed for infection or another reason, as well as patients who met criteria for an implantable defibrillator, but because of their acute situations, such as COVID-19 infections or other events clinically going on, they didn't qualify for a permanent device at this point. So that was really the population that it was targeted toward. The device looked at 2 primary endpoints, a safety endpoint with a pre-specified goal of less than 15% cutaneous adverse events causing the patient to exit use of the device from the trial, and less than 2 inappropriate shocks per 100 patient months. The secondary endpoints were the incidence of successful conversions of life-threatening heart rhythms, as well as compliance. This was a multicenter, prospective, single-arm trial with a goal for enrollment of 290 patients. There were 70 centers throughout the U.S. that enrolled. The JEWEL system is unique among wearable cardioverter defibrillators. It employs 2 patches akin to what we would ordinarily apply in the in-hospital setting. One in the right prepectoral region, and then the other would be in the left mid-axillary line. And that patch has attached to it the battery system for the device. And there's a small, low-profile connecting cable between the 2. The device has a machine learning algorithm. Once it's applied to the patient, it initiates monitoring. And so there's no rate cutoff for the device, no morphology settings. The device learns the patient's own baseline template and works from there in terms of identifying life-threatening rhythms. It's waterproof so that the patient can shower. They can't submerge themselves in a bathtub, that sort of thing. But they can certainly shower and go on about their business. And it's designed to be wearable for up to 8 days. If a life-threatening rhythm is detected, the device takes 24 seconds to confirm the detection, then another 24 seconds of audible, tactile, and visual alerts to let the patient know that they're about to receive a shock, and the patient can suspend the shock by pressing 2 buttons on the system. So if they're awake and it's an inappropriate detection, it's detected noise, the patient can inhibit the device. And then the device will deliver an initial 150 joule shock, followed by 160 joule defibrillations for a total of 5 shocks. The device will also synchronize the cardioversion if it's an organized monomorphic ventricular tachycardia. But if it can't synchronize on the R wave, it'll just defibrillate the patient. The study met both its primary safety and efficacy endpoints. The effectiveness endpoint, the incidence of the pre-specified goal was to have fewer than 2 inappropriate shocks per 100 patient months, and that number was 0.35. The result was fewer than 0.35 inappropriate shocks per 100 patient months. And the incidence of adverse cutaneous events was 2.5%, with a pre-specified goal of less than 15%. Now, those cutaneous adverse events were defined as clinical investigator withdrawal of the patient from exiting the patient from the study. So the investigator had to exit the patient of the study regardless of the severity. So none of the cutaneous adverse events that led to patient exit were actually defined as severe. They were either moderate or mild events. In terms of the secondary endpoints, the compliance, which is a key component to this trial, was remarkably robust. The median compliance was in the neighborhood of 23 hours per day, with a mean compliance of 21 hours per day, with a pre-specified goal of patient compliance being greater than 14 hours per day. So 91% of the patients exceeded the goal of 14 hours per day of the trial, and which is really an outstanding result for compliance. 60% of the patients had no alarms through trial, and of those that did have alarms during the wearing of the device, around 89% of those patients had fewer than 1 alarm per day. So there were very few inappropriate alarms during the trial, and the median time of wear throughout the trial was in the neighborhood of 49 to 50 days. That the other secondary endpoint was the number of successful conversions, and there were 8 successful conversions in the trial, which far exceeded our goal of 1 successful identification of a lethal arrhythmia and successful conversion. So quite pleased with its performance in the setting of life-threatening heart rhythms. So all things being equal, really good outcomes from the trial. I think that the take-home message is that we'll now have, assuming the FDA approves the device, the electrophysiologists, heart failure doctors, interventionalists that have patients that are at risk for sudden cardiac arrest, but not candidates for an implantable defibrillator. Those patients will have another alternative, very likely have another alternative for a wearable device that can bridge them and protect them as their hearts recover or as they become eligible for a permanent implantable defibrillator. I think the next steps really are going to be to accrue mortality data. The easiest way to do this is probably from registries, but of course, prospective data is the most robust. But if we can identify in whom this device is most successful in preventing sudden death and gives actual survival benefit, which populations we see actual survival benefit in, I think it'll help us target use more accurately with the wearable system. And now that we have a system that has really superior compliance to what we've seen so far, I'm hoping that we'll see survival benefit from a wearable device.